Assalamu alaikum. My name is Kiran Amir and I'm the Director of Operations at PARSA ECHO Pakistan Super Hub. I would like to welcome you all to our sixth session in ECHO series on inflammatory bowel disease. It's in collaboration with South Asian IBD Alliance, SAIA, a charitable organization, and PARSA ECHO Pakistan, working as Super Hub of Project ECHO, Extension for Community Healthcare Outcomes, was developed in US to meet the needs of underserved using technology. PARSA ECHO Pakistan started as hub in 2017 and got the status of first ever super hub in Pakistan in 2021, following the guidelines of Project ECHO with an objective that community providers learn from through video technology to participate in guided practice with specialist mentors. They acquire new skills that allow them to treat patients otherwise referred out. Patients with chronic conditions get high quality care without travel and waiting. A special thanks to Genix Pharma for the unrestricted educational grant. Today's session is titled IBD Pediatrics, and our expert for tonight's session is Dr. Adnan Altaf, Associate Professor of Pediatrics based in US. Before we move forward, we have to go through some standard announcements. We are part of a global movement called Project ECHO based in USA with an objective to disseminate knowledge and best practices. We do protect patient privacy. So none of the information used in this session will identify any individual or patient. For maintaining discipline, you all are muted, but we do encourage participation. So you can unmute yourself for a question or use the raised hand option and chat box. By participating, you have given the consent for recording. The recorded session will be available on our YouTube channel. Link will be shared in the chat box. For CME credits, please contact Uzair, our coordinator. His number and email is mentioned on the banner. CME credits are affiliated with Jinnah Sindh Medical University. Uzair will share the Google form at the end of the session, which will be active for 12 hours. You are requested to fill it as soon as possible to avail the opportunity of CME. Please speak in Urdu or English, whatever language you are comfortable. Please fill the form shared in the chat box. I will now hand over to Dr. Lajpat Rai from Jinnah's Postgraduate Medical Center, Karachi, our co-moderator for tonight's session, for introducing SAIA and our speaker. Over to you, Dr. Lajpat. You are muted. Please unmute yourself.
Thank you so much, Ms. Kiran, for having me on this panel and moderate this very important talk on IBD in pediatrics. Hello, everybody. Good morning, good afternoon, and good evening, wherever you might be around the world. I welcome you all today to our talk on IBD in pediatrics. So first of all, I will give a brief introduction on South Asian IBD Alliance. Let me share my screen with you. Can you see my screen?
Yes, we can.
So let's start with brief introduction of South Asian IBD Alliance, Past Trust and Project ECHO Partnership 2020-23. So South Asian IBD Alliance is the first patient clinician lead non-profit organization in the IBD space. With the dramatically increasing members of IBD in South Asia, SAIA has formed to create resources, research and education for IBD patients and healthcare providers of South Asian origin to minimize disparities, dispel stigma, promote early diagnosis and improve access to treatment. So they have three main components, which includes patient outreach and advocacy, research, and professional development. This is a slide showing the board of members of which have 4 IBD patients, 1 dietitian, and physicians from across the globe. So first of all, let's talk about the professional development. So this is the CME programming to educate general practitioners and gastroenterologists about IBD, its pathogenesis, epidemiology, and how to provide the best care and treatment options to patients in resource-limited setting in South Asia. So regarding the research manuscript, they're published in the Lancet Gastroenterology and Clinical Gastroenterology and Hepatology Journal and Gastroenterology Clinical and North American Journal. So in research initiative, Body and South Asian IBD Alliance named winner of Innovation Challenge in collaboration with Bristol Myers Squibb and additional unmet need in inflammatory bowel disease. And in patient education initiative, they have video content, digital content, and video content. They have clinician patient live stream on Facebook. All talks available on South Asian IBD Alliance. This is the link. You can click on it and see all the information which is available on this channel. And in digital content, they have infographics, live stream, highlights, disease state awareness, slides on topic related to post, co-created, and clinician panelists. And regarding the patient support group, the goal is to make sure no IBD patient feels alone in their journey. Non-judgmental support for South Asian IBD patients and caregivers, 1,400 members, and spread the word. We are active on the Facebook, Instagram, and Twitter, and on LinkedIn as well. So I would love to introduce the speaker of today's talk, very renowned Professor Mohammad Adnan Altaf. He's a Chief Pediatric Gastroenterology, Hepatology, and Nutrition. He's Associate Professor of Pediatrics, OU Children's Physician, Mercy Hospital, Oklahoma. He's a Program Director in Pediatric Gastroenterology Fellowship and at the University of Oklahoma Health Sciences. He's a Director in Pediatric Endoscopy and GI Motility Program, Children's Hospital at OU Medicine. His special interest includes researches in pediatric gastrointestinal motility disorder, chronic functional abdominal pain, aerodigestive disorders, IBD, neurogastroenterology, constipation, esophageal atresia, and strictures, eosinophilic esophagitis, Hirschsprung's disease, pediatric feeding and swallowing disorders, GERD, and reflexes. Over to you, sir.
Assalamu alaikum. Good evening, everyone. Thank you again. Thank you for allowing me to be part of this this great, I think, venture between and collaboration between, I think, between especially the United States and the South Asian population as well. I think especially, I think you've got all very esteemed physicians, I think, working in South Asia. I think it's definitely an honor and a pleasure kind of stuff to be here and be able to talk in any way that we can contribute back to our home countries as well. I think it's always been a challenge to how do we get involved back in our home countries. But I think anything we can do to help with that, I think we're definitely are very honored, and we are greatly, I think, appreciating for the collaboration that we're able to provide this platform to be, I think, be able to do that. So thank you again for PARSA ECHO as well, and South Asian IBD Alliance, and all the physicians that are involved and all the people that are involved in this collaborations. Thank you again for allowing us to be part of this. Again, the topic that I think chose today was inflammatory bowel disease in children. So it's a very like a quick overview of the IBD in general, and then maybe some specifics to the pediatric population as well, which are a little different than the adult population. So I think that was a task given to me to talk just an overview. It's not going to be very in-depth talk about the IBD itself, especially the medication and treatment part, but I think just to get a little bit of overview as well. I think there was the plans to talk more in depth of IBD and pediatrics in the next few months as well. Especially, I think Dr. Sabina Ali, I think, has been the co-director of this talk from the collaboration from the United States, and I think she's one of the international expert for IBD in children as well. So I think it was a plan to do that. So I think I'm gonna keep it quick and overview. There's some slides that I'm gonna go through quickly as well. Just to, I think the idea was to just give you an idea that there are these options available from the management standpoint that we can get some guidance for, or we can use in our daily management. So I'm not going to go in detail for some of the slides during this talk. So again, inflammatory bowel disease is a chronic relapsing remitting condition that we all know involves the GI tract, and we definitely have some excellent manifest disease, and some percent of the diagnosis that is usually called indeterminate colitis. They were not able to differentiate between a Crohn's disease or ulcerative colitis. And especially in pediatric population, that about 10% of kids will change their diagnosis during the evolution of the process of the disease as well in their lifetime. And most of them, I think, probably will change from ulcerative colitis to Crohn's disease, but there is a change over time that happens as we know more as they get older during the disease process as well. And then we have the very early onset IBD, which is involved the children less than 6 years of age, and it has a little bit different genetic polymorphism as well. And we have another subset of that, which is called an infantile IBD, that involves the children less than 2 years of age. These are the population that I think a lot more research is going on at this time because there is a concern for immune deficiency related disorders and overlap in the Crohn's disease, especially as in pediatric IBD, to know more about the very early onset IBD and the treatment that might be more specific to that group that might not be generalized to the rest of the IBD. Briefly talking about the epidemiology as well. So I think in the study, they talked about the 4 epidemiological stages in evolution of IBD in the world as well. And it starts with the emergence, where basically you had increase in incidence and there's not much prevalence yet. It's mostly sporadic cases that at this time, that again, in the industrialized countries as well, it happened a long time ago, but that's changing over time as well. As the developing countries are becoming more industrialized, it changes over time. And then you go to acceleration in incidence phase, which again, the South Asia is in this category at this time, where basically the prevalence is still not that much, but the incidence is increasing significantly at this time. And then you go to the compounding prevalence phase, where the incidence gets stabilized a little bit, but the prevalence exponentially increased over time as well. And then it leads to the prevalence equilibrium phase, where basically it's going to be at a point where basically the incidence is going to be stabilized, and you have a growing age population as well, where the prevalence is going to be also be stabilized as well. So again, it changes over time that you can see that the more Western world are already in the compounding prevalence or the prevalence equilibrium phase, and the South Asia is in acceleration and incidence phase, and it's going to go into compounding prevalence phase. So I think what the again, this map of the world shows the same thing as well, that South Asia. So I think the whole idea is that we can learn from the regions that are already in the compounding prevalence or prevalence equilibrium phase, and we can learn from the management there, and they can utilize those things that might have been missed in those countries, and we can improve the clinical care now, which basically we're seeing an increased incidence in especially in South Asia. So that's, I think it helps from probably from that perspective. But again, we're seeing the same thing as well from the other autoimmune disorders as well, that all the other autoimmune disorders are increasing over time as well. And we're seeing the same with the type 1 diabetes, multiple sclerosis, asthma, and we see that over time, we're definitely seeing a lot more incidence in this. There are different theories for that. One of the theories is hygiene theory, that we are too clean. I think growing up in Pakistan, again, we drank from water from the tap and we all got sick over time. So I think our immunity got adapted to that kind of a exposure to those infections. So that's why maybe when we get an infection now, our immune system does not really go out of whack kind of stuff and then start responding hyper response kind of stuff to and develop some kind of autoimmune disorder. So I think that's one of the theories as well. I'm sure there's a lot more theories behind that, including the food and the pesticides and the other things that we use in the food industry as well. So there's a lot of theories behind that, but we're definitely seeing overall the incidence, all autoimmune disorders are increasing as well over time. And absolutely there is more increased awareness to diagnose those as well. The about 10 to 30 years is the age we're usually seeing a peak incidence of diagnosis of IBD. Again, the 25% of IBD is diagnosed in children, and the mean age that we see that is between 11 and 13 years of age. Overall, the total IBD is definitely around 9 to 10 years of age plus onwards, that we're starting seeing some more incidence increase in diagnosis at that age range. So a little bit of differences between the natural history between pediatric IBD and the adult IBD. Crohn's, again, mostly often involved, the colon is more involved in the Crohn's as compared to adult, where basically you have more ileum that's involved. And the Crohn's is more extensive, where the adult is less succeed. And for Crohn's as well, for pediatric, there is definitely more progression in the first decade, versus in the adult onset, the disease extension is less common. For same difference between ulcerative colitis as well, that most of the time we see pan colitis or extensive colitis in pediatric population, versus adult, mostly we see is left-sided colitis. The pediatric ulcerative colitis tends to be a little more aggressive, where we end up in a need for colectomy within 10 years of diagnosis, where adult onset is usually the ulcerative colitis, you don't lead to the colectomy for quite a few years, as compared to pediatrics. So again, we know that IBD is multifactorial, again, like any other autoimmune disorders as well. Please go ahead. I think somebody raised a question, hand, I think. I think etiology for the IBD was susceptible hosts that, but by itself, that's not enough. So you have to have second, third, fourth hit theories as well that place in the wrong time, that you have other things that can lead to inflammatory bowel disease. Again, environment with all the food triggers that we know that there is a concern. And then the microbiome is definitely one thing that we have increased in certain pathogens as well, and a decrease in certain pathogens in our intestinal flora that can predispose us to develop IBD over time as well. Again, I think we do all get infection. It's natural progress to any kind of chronic disorder. But then in IBD pathogenesis, that's where I think the immune system is very over-infection or virus is gone, and that's what leads to attacking the same immune cells, attacking the intestinal cells in IBD, or joint cells in rheumatoid arthritis as well, that can lead to development of an autoimmune disease. We have more than 200 plus genes identified. I think there is a lot of work done the last 20-25 years in IBD genetics. And there's a significantly large number of genes, especially with the whole exome sequencing, that they've been able to identify. In pediatric, there's a definitely higher significant genetic predisposition as well with the first degree relatives. It increased up to 15 times more as risk as compared to the general population. Definitely, it's more prevalent in Crohn's disease that we see that genetic association as compared to ulcerative colitis. So there has been one study that have looked at some of the genes. Most of the studies or work has been done in Europe or United States or Canada. So we are seeing a lot more genes that are more susceptible in the Caucasian population. But then there are some genes that are work being done in South Asia as well. And again, there is some. This study actually looked at the Southern in that population, and some genes are overlap between Caucasian population as well. So I think this will be definitely one of the fields to expand in the next few years, especially for South Asia, to see, because the drug therapies that are coming out are targeting some of these genetic defects as well, or concerns. So that will be definitely interesting to see that if the treatment would be a little different for ethnicity triggered, like a population as well that has different ethnicities based on these genetic results that we will hopefully be able to find in the next few years. There are always a concern from a dietary standpoint. The dietary is one of the biggest environmental trigger in developing IBD as well. Again, the more of a westernized diet with animal fat, proteins, and refined sugars in excess is definitely one of the same fibrils turn for the trigger in the environment. Breastfeeding, there is some shown some protective role in IBD. Again, there are some studies being this is one of the studies that have looked at so we had a Montreal classification which is done for adult. So this is which is specifically for the pediatric population. Is L3 entire colon, which is different, which is again is different than adult population, which is mostly in left-sided colitis. So again, there is the difference between pediatric is that extensive involvement. Crohn's is mostly inflammatory versus only 20% in adults is, I'm sorry, the ileoclonic location is 60% in pediatrics versus only 33 to 20% in adults. The ulcerative colitis, again, usually you see pancolitis in children versus only 48% in adults. And then the severity definitely progressed rapidly in the first decade of life. I'm sorry, the first decade after diagnosis for pediatric population as well. So this is one of the studies that are done, I think from Karachi as well, with Dr. Bilu Ghaffar and Dr. Aziz, who looked at about 50 kids in that population as well. I think I'm saying at Al Khan University Hospital, and they in this study they definitely had more, about 60% were ulcerative colitis versus 20% were Crohn's and 20% were intermittent colitis. But again, if you look at the location of that population as well, then again 65% were pancolitis for ulcerative colitis and 70% were ileoclonic, which is exactly the same that are studies that have done in Western like a hemisphere as well, that has shown almost a similar location in pediatrics. So it seems like that can be universalized for pediatrics in South Asia as well as the United States and Europe as well. One of the other studies I think looked at, this is from Lahore, from Dr. Chima, that very early onset IBD, they looked at about 2 years of data and they looked at about 60 children. And in that study, they had about 60% had ulcerative colitis, 50% had monogenic IBD, and about 84% were males. And their mean age of diagnosis for, again, monogenic and non-monogenic IBD, I think they separated out, which was younger for monogenic IBD versus non-monogenic IBD. And again, there are more studies, again, coming from Pakistan as well, or South Asia for sure. I just looked at a few studies to get an idea, how does it compare to the United States or Europe as well with these studies. So again, there's a lot of work going on in Pakistan already as well. And I think the genetic exploration, I think, is definitely one thing that I think it probably needs to be worked on to see what the differences are between the ethnicities or the regional population as well as compared to the Western Hemisphere. I'm briefly going to talk about the diagnosis. Again, I think important goal for diagnosis is to differentiate between Crohn's disease and ulcerative colitis. We understand that 10% is going to be indeterminate. And again, some of the therapies do not necessarily make a difference, but there are some that are more efficacious in one versus the other. And that's why I think it would be important to know the diagnosis early on when you're making the diagnosis. Also, the extent of the disease matters as well, because we need to know what the extent is, because some therapies are more effective from the location standpoint, and then looking at the behavior as well, because again, it's not necessarily that a step-up therapy which kind of gone away from in the last decade or so or more, that it's no step-up therapy anymore, that we do more regional look based on more of the behavior of the location as well, to change, to do the therapies based on that. So again, the diagnosis is multiple levels, like being examination as well, with the history and diagnostic testing as well, that combines in the diagnosis. We know that I think there's a differences between a Crohn's and ulcerative colitis from symptom-wise. Some are more common in Crohn's versus ulcerative colitis. And of course, Crohn's disease sometimes presents, especially the small bowel Crohn's, it presents more like insidiously as well. And because we don't necessarily have hematochezia or diarrhea with that as compared to ulcerative colitis, we have a lot more symptoms and stool urgency. So sometimes the differences are a little bit more acute presentation for ulcerative colitis versus more insidious presentation for the Crohn's. So again, we definitely have a high suspicion of diagnosis. We need to rule out the infectious part as well with again, stool culture, C. diff, tuberculosis for sure, especially in South Asia as well, because that can present like an IBD. And then we try to classify look at the location and classify the disease with the endoscopies, contrast studies, and imaging studies like a CT. And then we look for external intestinal manifestations as well. Again, there's a little bit of algorithm as well that I think one of these studies had published that. And again, I think it's more we need to have a multi-tier evaluation at different levels. Again, starting from the lab is helpful from that standpoint, and ruling out something like a celiac. The stool studies, stool calprotectin is one of the important things that we usually look for. Again, in the last, I would say probably 5 to 10 years, we definitely are relying more on stool calprotectin to differentiate between irritable bowel syndrome or IBD as well. So, and then also using stool calprotectin in monitoring of the disease status or remission as well over time. So that is something new that we kind of started using a lot more in the last 5 to 10 years, I would say. Again, anytime we do the upper endoscopy and a colonoscopy, we always do upper endoscopy, especially from a pediatric standpoint, because we look for upper intestinal changes from a Crohn's standpoint, which is definitely more common in pediatrics. And again, doing a colonoscopy, at least in here, in our adult practitioners here in US, they are less likely to intubate the terminal ileum and get the ileal biopsies, which is a lot different than pediatric population because our main location is ileal. So we do want to always intubate the ileum and get the ileal biopsies, even if it looks normal as well for the extent of the location as well. So that is something different than we do here, at least in the United States. There's a little bit difference in practice style. Again, for more people who are more IBD specific, then of course, I'm sure everybody looks at the ileum as well at the same way they look at the colon. I think once we diagnose Crohn's and ulcerative colitis, for Crohn's, usually the recommendation is to know the extent of the disease. So usually some kind of a small bowel evaluation is recommended. So either you do a small bowel contrast studies or CT angiography, MR angiography, or a capsule endoscopy. But that's what recommended to do some form of small bowel imaging at the onset of diagnosis to make sure the extent of small bowel involvement, which can lead to disease complications long-term as well. If the scope biopsies are normal, then I think the question is, could you have isolated small bowel disease, which again, definitely is common in not common, but seen in pediatric population more so. So some form of imaging study with possibly doing a capsule endoscopy also afterwards is recommended, because sometimes if it's like small ulcers, you might not see extensive disease on the imaging study, and the capsule endoscopy might be the only way to diagnose that. Again, differentiating between the ulcerative colitis and Crohn's, of course, ulcerative colitis only involves the colon and the rectum, and the rectum is always involved as compared to Crohn's that we have any part of the GI tract that's involved, and the rectum is involved only in 10% of the cases. Ulcerative colitis tends to be more superficial or mucosal, submucosal, versus Crohn's goes through the walls of the intestinal tract, and that's the reason we develop more strictures and fistulas in Crohn's more than ulcerative colitis. Again, we have a continuous pattern of ulcerative colitis, so we always have the rectum involved, and then the extent is variable as compared to Crohn's, that we can have skip lesions that we go on. I was talking about the acute onset before as well, because colitis usually has a lot more urgency kind of symptoms with like hematochezia, diarrhea, tenesmus. So usually you present much more quicker as compared to the Crohn's, that you might have more malabsorption symptoms as well, and some chronic nausea symptoms from inflammatory cytokines. So that might be more of a chronic like a symptoms that might present a little more insidiously. And again, 10% of that is intermittent colitis, where we might not be able to diagnose one or the other for sure. And that something has to be labeled as such, so we don't forget that we have not been able to diagnose 100% between Crohn's and ulcerative colitis. But then I think there are, especially in pediatrics, that we have kids who we treat them for years, and we do every and at the end, if you're doing almost getting to the point where you're doing a colectomy for let's say ulcerative colitis, and that's how the diagnosis was, because we failed all medical therapy. And at the end, if you go to, usually we like to reevaluate completely before we do colectomy, again, for the same reason. So if you know what the ulcerative colitis or Crohn's is, and we do all imaging studies and all scopes, and then it's still our diagnosis of ulcerative colitis, but at the end, when we get the colon specimen back from pathology, they see granulomas in the colon as well, because now they're looking at the whole colon biopsy specimen versus just the piecemeal pieces. So again, it's sometimes difficult to differentiate, but again, we do try to do our best to differentiate between the two as much as possible. Again, we talked about that briefly. There is more acute kind of symptoms with ulcerative colitis. There's a lot more pain, diarrhea, discharge, bleeding, tenesmus kind of symptoms. And that's what we see usually with ulcerative colitis, that you have more prominent tip distortion as well, that looks for chronic changes. There is a Mayo endoscopic score, I think same as for adult and pediatric, that we can be used. Again, these are used mostly again to help if we are talking to somebody, that at least we have an idea that what kind of a severity the disease was and what you were able to see on endoscopy as well. So I think it helps kind of stuff to collaborate, and also from a research standpoint, it helps as well that we can collect those data prospectively, retrospectively, and look at it if there's something more preferable in different classification of disease as well. For Crohn's, we talked about briefly that we have inflammatory component, especially in pediatric. That is the most significant component, is B1, which is the inflammatory part. But as we go with the diagnosis and we progress over time, that as we know that we definitely progress in pediatric population, that we can lead to stricture and to B2, and then can also lead to fistulas and abscesses, which is again a transmural inflammation all the way towards the serosal side, will lead to more inflammation, leading to more abscess formation as well. So again, the whole theory behind the stricture is that again you have then inflammation, and then you heal that and it gets better, then you have another flare up, then you have another inflammation as well, then you have flare up, then you have another inflammation part. So I think if you have repeated bouts of flare up and inflammation, that's what leads to fibrosis and scarring. So I think trying to keep the disease under better control and have as less flare up as possible helps in the long-term complications of IBD. So there is a reason for us to be not on necessarily aggressive therapy, to be on optimal or adequate therapy. That means that we can keep these flare-ups at very minimal to help prevent the long-term complication of strictures, fistulas, and abscesses, and needing surgery over time. So I think that's the rationale behind being, again, optimal therapy, not necessarily aggressive therapy. Because I don't think there's any word of aggressive therapy. I think whatever therapy that we need to keep things under control is the optimal therapy that we need to do. And our clinical symptom for Crohn's, of course, varies based on the type of the disease that we have, either inflammatory part or stricturing or penetrating, and we look for those things. So I think we have a low threshold to look for obstructive symptoms as well, especially for ileoclonic Crohn's or ileal Crohn's. There's very high risk of strictures formation in the ileum, and sometimes the problem is that they present with that kind of a symptoms of obstructive symptoms as a presentation at diagnosis. And that's how they present, because again, it's been going on for a while, but especially just a small bowel disease or the ileal disease only, it presents a lot more insidious onset. So we have disease for a while, so by the time they present, they already have a stricturing component. But again, of course, we don't know if there's an inflammatory part or there's a fibrotic part. They just have a stricture. And again, but then we need more optimal, again, therapy to manage them, but also monitor them over time as well, to see if how much is the fibrotic part and how much is the inflammatory part, that we're able to open up the stricture or not. So that, again, those symptoms will vary over time. And then, of course, the fistulizing or penetrating disease is a little bit more complicated, that comes in with abscess. That again, with any kind of abscess, we need to be a little more again, aggressive on that therapy as well, to make sure that we're treating it effectively. Again, we kind of talked about briefly that as well, that you need to healthy, then you have inflammation, which is narrowing from the mucosal side, and then you develop a stricture, then ultimately that leads to more dilation in the proximal part as well, which ultimately lead to more transmural inflammation and bacterial overgrowth that can lead to some translocation as well, and end up with the fistulas and abscess formation. Again, the left side is normal colon, nice mucosa, in the middle picture is the deep ulcerations, and then again, the right side is ulceration in the ileum that we have more extensive involvement usually that we see in pediatrics. Again, so these are the small bowel imaging that we can see, going from a contrast studies like small bowel follow-throughs to MR angiography and a CT angiography. Of course, the MR is a lot more preferable, especially in a pediatric population as well, because the risk of radiation cumulative over time in somebody with IBD is significantly high. So anytime we can avoid radiation from a CT scan, that's much more preferable. But then the issue is that even here, we're not able to get an MR that quickly, especially if our pediatric population needs sedation to stay calm during the MR. So we end up getting a CTs, or in the ER, it's a lot more easier to get a CT scan to rule out for abscess. Because again, if they're presenting with fevers, our treatment does change with an abscess finding. So, but any kind of imaging definitely is helpful for us to look at. I think the MR here shows some small bowel disease in the ileum, more thickening and separation of the intestinal loops. And then on the right side, the CT angiography looks at more extensive small bowel involvement there. On the left-hand side, I think if I see that's one of the imaging study as well that looks at the ileal stricture. You can see a nice ileal stricture going around. So I think the problem with the MR and CT is it's not a dynamic study. It's a static study one time. So you do get some more benefit of looking at the mucosa and the thickening and abscess and stricture. But if it's a short stricture, then you can easily miss that. So that's where the small bowel follow-through, sometimes being a dynamic study, you're able to look at that as well. But now with the newer CT scans, the radiations is much lower than sometimes doing a regular fluoroscopy small bowel follow-through. So that's why I think we kind of change our practice to more of a CT or MR, preferably again, but do a lot less small bowel follow-throughs, which are the X-ray fluoroscopy studies. So again, the capsule endoscopy is ideal to do that, looking at especially a subset of population where we are not able to identify the extent or the symptoms continuing with normal scopes and normal imaging study as well, but you have a very high suspicion, let's say very high calprotectin, and you still have a very high suspicion, then I think the capsule endoscopy is a very reasonable diagnostic tool to use in this setting. The concern I think for the capsule endoscopy would be that it's a single large capsule with the 12 millimeter. So with our concern for ileal Crohn's especially, or small bowel Crohn's, and very high risk or incidence of stricture as well, then you don't want to put a capsule in and get stuck in the either inflammatory stricture or fibrotic stricture, because sometimes you might not be able to open up the stricture if it's not inflammatory, and you might need a surgery to resect that part, and of course take the capsule pill cam out as well. So I think we need to do either some kind of angiography, small bowel follow-throughs, or MR-CT angiographies to make sure there's no stricture concerns, or you can do a patency capsule as well, which dissolve in about 30 hours. So you can do a patency capsule, and if you can do an X-ray right before 30 hours, and you can see that there's no capsule and it's already been expelled, then the patency is optimal to put an actual capsule endoscopy pill. The biopsies, of course, we look for granulomas, but again, we don't see granulomas always in Crohn's. You can make a diagnosis of Crohn's without the granulomas as well, based on the location and the phenotype of the findings. Again, of course, we look for caseating granulomas as well for other non-IBD diseases as well. Again, we look for intestinal manifestations, a lot more common in Crohn's than ulcerative colitis. Especially the skin manifestations, either the oral aphtase or the erythema nodosum or pyedoma gangrenosum as well. So those are the important things to look for. We definitely have concern for uveitis, and we need more chronic monitoring from that standpoint in Crohn's. And then we have a joint involvement, especially the sacroiliitis is common finding, at least in pediatric population, that we see from time to time. One of the important things that I think I'm going to briefly quickly talk about is a growth failure in pediatric population. That is definitely one of the main concerns that we have, both at the diagnosis and also during the course of the IBD as well. We see about 35% of pediatric IBD has some form of growth failure. Again, pre-pubertal Crohn's have a significantly high number of that, and we see a lot less in ulcerative colitis as compared to Crohn's. And if you see that growth chart on the right-hand side, that's at the diagnosis. You can see that before the diagnosis, you can see that the height and the weight velocities both starts to plateau until you get to the diagnosis. And then you see both improvement in both height velocity and the weight velocity. But if you look at the height velocity on the right-hand side, the end, that it never reaches the potential that was before. Before, I think it's almost about 25 percentile for the height velocity. But then at the end of that, even doing better on treatment, you're still not able to get to the 25% of the height velocity. So that is a concern that, one, it presents that way. Sometimes the height growth failure is one of the main presenting sign for IBD in pediatrics. So we do definitely want to pay more attention to that. And second, that it might not be able to even achieve the pre-IBD diagnosis potential or genetic potential, even despite of adequate treatment. So there's definitely a concern, and it's multifactorial for sure. There's one of the studies by Dr. Himes in the US they've done. They looked at about some kids with IBD, and they differentiate between the mild disease and a moderate to severe disease. So on the left-hand side, if you look at it, the blue column is a no prednisone, and the yellow column is a daily prednisone. So you can see the difference in mild disease. The kids who were on daily prednisone had a lower growth velocity as compared to the kids who were not on prednisone. But then if you look at the moderate to severe disease, overall, of course, the growth velocity is less as compared to the mild disease at general. But then if you compare the prednisone group and the no prednisone group, you see a significant decrease in growth velocity on a daily prednisone group. So I think there is, and they talk with the collagen, that there is some decrease in number of procollagen being on steroids. Even 48 hours of being on prednisone can decrease the number of procollagen that can lead to the growth failure over time. So definitely there's concern for being on short-term steroids and long-term steroids. And that's where the emphasis is to try to get them off the steroids or not have to be on steroids for pediatric population for sure. Again, it's definitely multifactorial, with the malnutrition being one of the main things that contributes to the growth failure. And those are the reasons are higher. There's malabsorption, there is increased caloric needs as well. There is a suboptimal intake for all the symptoms. And that leads to growth failure, but also having some inflammation and corticosteroid effect also can lead to growth failure by itself. So I think it's definitely multifactorial, and we need to address things overall, not just look at one thing. But I think it's one of the important things, because we lose the genetic potential for the growth failure if we don't diagnose on time, and also if we don't treat effectively, if we don't monitor effectively. I think we definitely get in trouble from the pediatric population from that standpoint. And the one thing is that I think there is a collaborative network here for pediatric called ICN, or Improve Care Now, which is a national, now actually is international collaborative network. What they do is they put a lot of emphasis on things that we never used to check. And height was one of them. Then now, so you have to measure the height every 3 to 6 months when they come to the clinic, and you need to plot them on a growth chart to see what's happening with their growth. Because if they have no clinical symptoms, but their growth is velocity or growth failure is a concern, then I think you need to reassess the status of their Crohn's remission. So I think it has changed our way of managing in pediatrics for the last 15 years or so. So I think we definitely pay a lot more attention than we used to. And the same thing goes for corticosteroids, that we try our best not to use, or use very minimal duration of, and the lowest dose if possible in pediatric population for sure. Again, as before, I think controlling the disease is important for sure, because that's what helps. And then optimizing nutrition, promoting more physical activity, minimizing the steroid use are all important factors in helping with the growth of these young patients. And I'm gonna, I think, talk quickly about the treatment for IBD as well. What are the approaches and goals? And then there is, if you can separate them out between mild and moderate to severe IBD, and then again there is lots of response that how do we manage that? So I think one of the main goals of treatment is initially early on is induction of remission. then I think we go to maintenance of remission. So there are two important goals from the management standpoint that we need to definitely get the inflammation under control as quickly as possible and normalize all the clinical symptoms, but also the lab markers and the growth as well. So we need to do that quickly, but then we have to maintain the remission again with no steroids. And we need to have a secondary agent to help with the maintain the remission and not use steroids as a mainstay for remission. So try to get them off steroids as soon as possible. But the third phase is the disease monitoring and prevention. And that is an important part as well, that we need to do any things we can do that can help us prevent some relapses and monitor the response, and of course, prevent the complication as well. So I think that is an important aspect of the treatment, long-term treatment for IBD. And that involves, we can do some proactive measures that help us prevent some relapse. So in pediatrics, there is I'm just going to briefly talk about this. There's a pediatric Crohn's disease activity index, or PCDAI, and there's a short PCDAI as well. So again, it looks for different things, and that's what we usually use here from our Improved Care Collaborative Network, that look at different things, and it just gives you an objective way, a little bit objective way, rather than just a subjective physician global assessment, which basically subjectively looks at all these things. But this looks at objectively a little bit on those things, and you can measure the numbers, especially if there's somebody's admitted to the hospital and you're looking at every day. I think these measures sometimes help to see if the scoring is improving on your treatment as well. Same thing is for the ulcerative colitis. You have a pediatric ulcerative colitis activity index. And again, there are different things that you look for. And there is a scale that differentiates between the mild, moderate, severe. Again, you'll have a physician global assessment that you'll how you feel, but that's more subjective. So that it gives you a little bit of objectivity to that global assessment as well, and helps you compare over time how the pediatric population is doing during the management of IBD. One of the important aspects for treatment of IBD is mucosal healing. That definitely there are multiple studies that have come out and says that we need to look at mucosal healing and not just a clinical remission. So there's a clinical remission and there is a histological remission, or endoscopic and histological remission. So I think we need to do more endoscopic and histological remission to prevent long-term complications and have adequate control of the disease. Again, we're going to talk about a few different medications groups. Aminosalicylic acids are different medications that are used as an anti-inflammatory. They have a topical effect, and they help inhibit the prostaglandin E2 and leukotrienes as inflammatory cytokines that helps with the inflammation. And there are different release formulations for these medications that can be used for different diseases, like extended disease as well. And again, there's enema suppository form that can be used for either proctitis. But again, there is not a lot role of aminosalicylic acid in Crohn's anymore. So this is mainly recommended for more mild ulcerative colitis. And for Crohn's and for moderate severe ulcerative colitis, then again, the biologicals are one that's recommended. Antibiotics, there's definitely a role of antibiotics in managing IBD. It's not a very specific, like a organism-driven antibiotic. It's a generalized response for antibiotic that can changes the bacterial flora as well and lead to some help. But again, the role of antibiotic is as an adjunct in more, especially a complicated IBD, not as a sole therapy for IBD. Exclusive enteral nutrition therapy, again, used extensively in Europe and not as much in the United States. But then there is a significant anti-inflammatory properties of exclusive enteral nutrition that improves the epithelial barrier function, and of course modulates the intestinal flora that ultimately helps from the IBD pathogenesis standpoint. So what exclusive enteral nutrition is basically where you are, it can be used for both induction and maintenance, both. But it means for the induction, it's 100% liquid diet for about at least 3 months to see the induction, and it's comparable to steroids in some studies. There are always some different studies that have shown different results, but comparable to steroids in induction remission. But you have to be on liquid nutrition for 3 months, and then for maintenance, it's about 90% liquid nutrition for your caloric needs of the day or intake of the day, and 10% is oral intake with non-liquid diet. So that's what the exclusive enteral nutrition is. I think it's been used in Europe. Again, if you're trying to stay away from the immunosuppressive medications, it's more preferred or has much better data in small intestinal Crohn's only, like only small intestinal Crohn's, and not in small and large intestinal Crohn's. There were some initial studies that talked about the elemental formula, the amino acid based formulas, but now I think they say any polymetric formula is good enough for that use. But again, it's about 100% liquid nutrition for 3 months and 90% for longer term for remission, which is sometimes difficult from the quality of life standpoint. But again, in Europe, they are able to use that very extensively as compared to the United States. Immunomodulators or biologicals, I think they're definitely for Crohn's disease, that's what recommended. For moderate severe ulcerative colitis, that's also recommended. It's not necessarily aggressive therapy. Again, it's an optimal therapy that is much more efficacious as compared to other modalities. Again, if you have any extensive B2, B3, like fistulizing, penetrating, stricturing disease, then definitely, or corticoid dependent or resistant disease, then definitely you need to consider these medications. For immunomodulators, azathioprine, 6-mercaptopurine, or methotrexate are some of the medications that we talk about. Again, there is not a lot of role. One, it takes a while to get them see an effect from it, and it's not have a lot. Newer studies have not shown a significant results for using as a single agent for primary induction. So there is a lot of use as a second adjunct medication to the biologicals in controlling the disease. And there were some studies that have come out in the last few years about 6-mercaptopurine, azathioprine, that the cumulative risk of cancer is much higher, where the efficacy as compared to placebo was not that great. So it's recommended not necessarily to use that, especially in pediatric IBD, to use that as a first agent or a single agent. But again, there is definitely data to support its use as an adjunct to the biologicals in complicated IBD. Then there are different biologicals. Again, there are some brand names and generic names here, which are like either anti-TNF or IL-12/23 or integrin antagonist. And there are more newer medications that are coming out. The JAK inhibitors are the newer ones that have come out. Again, most of these are not FDA approved in the US for pediatric population. The infliximab and adalimumab are the ones that definitely are approved at this time. Again, there's one of the studies that have shown some data for in comparing the growth parameters at 1 year between an early anti-TNF, which is infliximab or adalimumab, or early immunomodulator therapy, which is the 6-mercaptopurine or methotrexate, and no early immunotherapy at all. So if you compare them, that anti-TNF therapy, definitely the growth velocity increased by 0.14 z-score, versus the immunomodulator or no early therapy had a little bit of no effect or negative effect. So you can see that there's definitely a difference, although the weight score, z-score, and the BMI z-score definitely gone up on all three of them. But if you look at the height z-score, the only one that made a difference was the early anti-TNF therapy, which is the Humira Remicade. So definitely there's a role in using those medications early on to help with from the growth standpoint. Again, this is anti-TNF, it's a chimeric between human and mouse. So we used to have a lot more reactions to the infliximab because of that, where we did not have the same reactions with the adalimumab, because that's all humanized monoclonal antibody. So infliximab is IV. Again, it's a weight-based dosing for pediatric as well. So the Humira or adalimumab is a sub-Q injection, but it's a humanized monoclonal antibody, so you don't have the same reaction that we used to have with infliximab. But the concern is that it's a standard dosing. There's not a weight-based dosing. So sometimes, especially in pediatric population as well, most of the drugs that we use are weight-based dosing. So sometimes we are going back to the infliximab from adalimumab if we have not seen the response to that. Especially, of course, there's more data for acute severe ulcerative colitis to using infliximab as compared to adalimumab. Then we have vedolizumab, which is a alpha-beta integrin receptor antagonist that is more gut specific. Again, more used for moderate severe ulcerative colitis or Crohn's. Again, it's an IV infusion as well. The stickimumab, the Stelara, the brand name here in the US, is an IL-12, IL-23 antagonist Again, human monoclonal antibody has a lot more significant role in Crohn's. And especially if you have psoriasis, then there is a good reason to use Stelara or Rituximab because it has some role in treating psoriasis as well as Crohn's at the same time. There's a newer version, Scarzi that have come out, which is more of IL-23 antagonist only, with the feel that might be some of the side effect might be from IL-12. So that is, again, more being used in adults as compared to pediatric, which is not approved in pediatrics yet either. Then you have the oral JAK kinase inhibitors that have been recently coming out. The Xeljanz and another one, Renovac, as well, that have come out recently. Again, more data in ulcerative colitis than Crohn's. Again, I'm not going to talk more extensively on this slide. I think we're running short of time. But then just to know that there is some kind of monitoring that we need to do before we start any therapy, and then during the course of time as well, that we need to be some kind of regular intervals, either annually or every 3 months or 4 months or 6 months. We need to do some kind of routine monitoring for these medications, because all medications have side effects. So basically some form of protocol that we need to use from monitoring these medications over time. Briefly on the therapeutic drug monitoring. So all of these medications, especially even the immunomodulators, but all these biologicals have antibodies and the levels that we can measure. So there's a reactive monitoring where basically if you're not doing well, then we do measure them and see if there's loss of response because of the low levels or antibody development. And there's a proactive that we do look for them to keep the levels at a much better level, so we might not lose a response. So that is one of the rationale for proactive as well, that if you have a lower level of the drug, then you develop antibodies against it. And by the time you realize, you might not be able to overcome the antibody or the loss of response. So sometimes there's the reason for a proactive monitoring, so we can keep the levels at an optimal and not get in trouble from loss of response or the complication that it can develop over time. We definitely have a decent number of patients that lead to surgery, both in Crohn's and ulcerative colitis. Again, having concern for dysplasia or non-responsive to any of the medications or complication of the diseases that can lead us to that direction. Briefly on the vaccination in children, for non-immunocompromised patients, not on immunomodulator immunobiological medications, there's no contraindication to live vaccines. But for immunocompromised patients, there is a concern for live virus vaccine, and that's contraindicated. And again, the BCG, oral polio vaccine, the MMR, varicella, oral typhoid. I think there are 2 typhoids. The oral typhoid is the one that is live, and then rotavirus is the live vaccine or live attenuated vaccines. So these are definitely a concern. So if we have a diagnosis, usually, again, in the US, there is an increasing population that are not vaccinating. So we have some regional epidemic of varicella and measles that broke out in different cities in the US in the last few years. So the reason I think we check it still is to make sure that if there is a prevalence in one city or region, that we can recommend people who are not immune. So we usually check for all these titers before we diagnose them. So, or when at the time of diagnosis, so we can at least know if they have a good immunity against these organisms or not. But again, regular non-live vaccines are all, I think we should follow the schedule as recommended. Again, the maintenance, again, is monitor growth. It's in pediatric, that is one of the very important, vital thing to follow over time. And the only way we can follow that is we plot them on the growth chart. So it's different than adult population that we don't use them. So definitely some form of monitoring is absolutely necessary for that. Then we look for other things as well with lab monitoring, the bone health, the DEXA scan, especially if you have more steroid exposure with that. And then we look for other things like mental health, quality of life, and then other preventing some other extraintestinal manifestation complications as well from the disease. So our goal of therapy, I think, of course, early on is induction of remission or clinical response and symptomatic improvement as well, and then normalizations of all the biochemical markers. But then I think we move on to the intermediate targets, which is basically decrease in overall the inflammatory load, and then also help with the growth of the children over time as well, and monitor that. And then the long-term goals are, of course, our mucosal healing, that we have the data now and improve the psychosocial mental health for the population as well, and then prevent any disability that we can by monitoring the drug side effects and monitoring them as well, and any complication of IBD, long-term IBD as well. So I think those are things that we need to monitor over our overarching goals for the long term that we need to keep in mind as well. So again, incidence is definitely increasing. I think you're definitely seeing we're in the increase in incidence phase in the South Asian region, but hopefully we can learn from some of the things that the United States or Europe or our people or regional countries here are using at this time, that we might be able to do a better monitoring, and the things that the studies that come out on the growth failure, especially in pediatrics, that we can look at the data now, so we don't have to go through the same things that we did not monitor in the United States or Europe. So hopefully this will help and getting to better clinical remission and mucosal healing, and trying to have a steroid-free remission long-term. That is the ultimate goal for us, to use the medications. Again, there's no aggressive medication. It's an optimal therapy or adequate therapy, which is effective for that the kind of IBD that the population has. And again, long-term monitoring is definitely helpful. Here, I think we have other non-physician members of the team as well that help us provide better care. Because there are things that I think, like the dietitian, we just not able to have the same kind of expertise that they will have from a nutrition standpoint, and psychologist and a social worker. So I think we use a lot of those, not always, but we try to have those team members part of the team to help provide a better care over time. And again, the Improved Care Now, which is ICN, or a Collaborative Quality Improvement Network, I think has definitely played a tremendous role internationally, especially nationally, but internationally as well, to help us provide better care for pediatric IBD. And a lot of this data is coming out of the ICN cohort collaborative network as well. Again, I want to thank you for inviting me. And again, it's an honor to be part of the team and all the members that are attending today as well. I think I really feel honored to be part of this team, and I think everyone is doing a great work back in Pakistan as well, especially, or in the South Asia. But I think anything that we can do, and this platform, I think really appreciate the platform. But I think this helps us do anything we can do to help improve the awareness or the education as well in any capacity that we can. I think we really appreciate that opportunity to be part of that. Again, the South Asian IBD Alliance, PARSA ECHO, Dr. Tausif Ali and Dr. Sabina Ali were the co-directors for the IBD in the United States as well. I think we really appreciate all their help. And again, we will be happy to be part of anything we can do, in just not in IBD as well, in any other part that we can do, from especially from pediatric GI as well, that we do have decent number of pediatric gastroenterologists in the US now. So I think we're trying to form our own cohort group that we can try to do some, when we come visit Pakistan as well, especially, that we can come and be involved in any kind of mentoring program that we can provide. And again, it's a learning as well. We learn a lot from people in ground in Pakistan as well, because the extent of the disease and the severity of the disease is a lot different. And sometimes we learn a lot from there. So I think it's a true learning process. But we really appreciate the opportunity, and thank you for everyone who is attending as well, for letting me talk today. I think I can open that for any comments or questions or suggestions. I think.
Thank you, Dr. Adnan. My name is Dr. Altaf. I'm one of the senior adult gastroenterologists here. I don't treat children, but I have a lot of interest in those. And fortunately, where I work, I have access to pediatric gastroenterologists. But your talk was very relevant for our region, because many adult gastroenterologists and even physicians and general practitioners have to treat IBD in children, because there is no access to pediatric gastroenterologists in many regions in Pakistan. So I thoroughly enjoyed your talk, and I'm sure we had a very good attendance. An eminent speaker like you was able to draw the attention of a lot of physicians here in Pakistan. So thank you very much for being here and enlightening us on the management of IBD in children, which is particularly pertinent not only for pediatric gastroenterologists, but general physicians, family physicians, and adult gastroenterologists where they do not have access to pediatric gastroenterologists. Thank you very much for being with us. Thank you.
Thank you. Thank you again. Thank you. Thank you for the nice comments. And I absolutely appreciate it. I think, and we see that in the United States as well, sometimes in smaller rural areas that we don't have access for pediatric gastroenterologists. We're still also not as the same, we are still short of pediatric GI even in the US as well. But I think there's a significantly large number of pediatric GI that are in the US now. They're originally from Pakistan. So hopefully, inshallah, I think we'll plan to definitely collaborate, and then I think we can reach out, and then if we can have some collaboration back in Pakistan when we come, I think we'll be happy to do anything that we can to serve back for sure.
Kiran, over to you.
Sure, we are running out of time. If you still have any questions, you can write it in the chat box. Otherwise, thank you very much, Dr. Noman. Dr. Adnan. This series is designed to have a session once in a month, so we will be planning interesting topics for you on monthly basis. So keep joining us and be part of the IBD series in the future. I think Uzair ne aapko IBD session jo next hai, it's on drug therapy on 21st June, and Uzair ne hepatitis echo ke session ka bhi registration link aapse saath share kar diya hai. We are again grateful and thankful to all the participants who have joined along with our expert and SAIA team, Genix Pharma for the unrestricted educational grant, and of course our director, Professor Altaf Saab, and team at PARSA ECHO Pakistan. So Allah Hafiz. Uzair, you can please call off the meeting. Thank you very much.
Sure, ma'am. Allah Hafiz, everyone.
Thank you. Thank you very much, everyone. Allah Hafiz.